Welcome to this Zoom webinar of the National Institute for Occupational Health, the NIH, in partnership with the Wits Health Consortium and supported by the Health and Welfare HWSETA. My colleague, Dr. Tanusha Singh, is not available at the moment. She's engaged with another important responsibility at NIH, and so I'm going to do the welcome on her behalf. So it's a great pleasure. I'm Ashraf Raycliffe, the National Occupational Health and Safety Training Manager here at the NIH, welcoming you to this session dealing with the management of persons under investigation for COVID-19, the experiences in different sectors of the economy, and we've got 4 guest presenters that's going to focus on their particular sectors. Just a quick short apology, sorry for the latest start. We had a bit of a technical issue just getting one of our guest presenters online, and we couldn't proceed without getting him connected. So welcome. The NIH is a division of the National Health Laboratory Services, a sister institute to the National Institute for Communicable Diseases. This is a webinar that's part of a series that's been conducted by the NIH since early March 2020 to deal with COVID-19 as a workplace issue, and to ensure that workplaces, employers, employees, all the occupational health specialists and occupational health and safety practitioners and functionaries are in a position to deal with workplace preparedness and the COVID-19 as a serious issue within the national health emergency that we're facing. The epidemic nationally and the pandemic internationally. So we know that the numbers are worsening. We are now climbing quite a bit with regard to the graph, and it's important for us all to make our contributions to ensure that the workplaces itself is not going to be a source of spread for the coronavirus, for the SARS-CoV-2. Okay, so I think we're probably at number 39 or 40 for our sessions. So this is a very important topic we're dealing with. It's another one in the progression with regard to the series of topics, starting with the general description of SARS-CoV-2 and COVID-19 as the disease, as an occupational and biological hazard, to the issue of risk assessment, the tools, the principles, as well as the controls required, and then eventually you sort of after lockdown dealing with post-lockdown return to work, and then the return to work of a COVID positive employee, and now we're dealing with the management of persons under investigation for COVID-19. I'm going to introduce our guest in a moment, and we will start with Ms. Kim Davies, and I would like her just to get ready to share her screen in a moment after Mr. Segi Pillay has given an introduction on behalf of the Wits Health Consortium. So just I will give you afterwards a quick admin with regard to where you must type your questions in the Q&A and where you must type your general comments in the chat box. But just to say that this session will be recorded, and all resources are then placed on the NIOH website, that is www.nioh.ac.za, www.nioh.ac.za, and that website is zero-rated by all the 9 major service providers, internet service providers in South Africa. So when you go there, you won't be charged any data for visiting or downloading from our website. So extremely grateful for this collaboration with the Wits Health Consortium and the funding from the Health and Welfare HWSETA that is providing, for example, also data for you if you're in the health and welfare and social development sectors. That data aspect is administered through the Wits Health Consortium. And I just want to check if our representative, Mr. Segi Pillay, the Chief Operating Officer, if I've got the title correct, is online. Segi, are you online?
Ashraf, I am. Good morning.
Thank you very much. I'm not sure if you want to share your screen, but I think you are in a position to do so.
Okay, there we are. Now, I don't have any presentation per se, Ashraf. Thank you very much for the opportunity. Colleagues, participants from around the country, good morning to all of you. and welcome to this session. We're really privileged to be part of this partnership with the National Institute for Occupational Health. I think those of you who've participated in the sessions up until now will know that the quality of the contributions, the content has been really brilliant, and NIOH has gone out of its way to respond to the needs of health workers and other support staff, to play our role in managing the pandemic. We are very privileged as well to be doing this in partnership with the Health and Welfare SETA. The Health and Welfare SETA, I must say, at very short notice, made funding available to enable this program. We wouldn't have been able to reach out to so many thousand people over the last 6 to 8 weeks had it not been for that funding. And two things. One is that they made a decision quite quickly, recognizing the need. And secondly, for those individuals that have been having difficulty with data, because data can be quite expensive, they also made some funding available to enable individuals to participate in the program. So we're really grateful to the Health and Welfare SETA, and we hope that they will continue supporting this initiative. The training programs themselves and the content and the titles, etc., have been developed after much consultation with labor, with other stakeholders, and we've come up with these with the program of activities. But I would also like to encourage participants in the program. If you thought there were aspects that are important and have not been covered or not being covered over the next couple of weeks, please write in to ourselves. There's an email address, and we'll try and cover those topics as well. The second point I wanted to make, as Ashraf had indicated, the situation in the Eastern Cape, in Gauteng now, is getting quite challenging. And in fact, the roles that all of us need to play in managing the pandemic becomes even more important. So these sessions that are being run are not just training sessions or information sharing sessions. They're really designed to provide you with a set of tools, to provide you with some knowledge, to provide you with an understanding where, irrespective of which stakeholder group you represent, whether you're a frontline worker, whether you're a shop steward, whether you're part of management, whether you're within the leadership of labor, we have a collective responsibility to ensure that we play our roles, to ensure that our workplaces are safe. And in keeping our workplaces safe, we take individual and collective responsibility for ourselves and for our colleagues, for patients that come through to the facilities at which we work, for clients that come into social development institutions, or customers that come in to your businesses, that we've done all that we possibly could do to provide you with the systems, to provide you with the knowledge, and to provide you with a better understanding of what are the guidelines that government and the National Institute for for Communicable Diseases are putting out regularly. So it's absolutely crucial that we play that role, that in fact we prepare ourselves and we prepare South Africa to understand and to live with the virus, because it's going to be quite a long while before a vaccine becomes available, and South Africa is playing a very important role on the vaccine side. So I hope that you will use this knowledge in that way, that you will encourage other colleagues and friends and family to participate in these training programs as well, that for individuals who don't have data, we can make data available, but if that data can be used responsibly, I'm sure that together we will be able to make the contribution to flatten the curve and return to some sense of normality sooner rather than later. Ashraf, thank you very much for this opportunity, and I wish all of you enjoy the session, but most importantly, go back and start making a difference in the workplaces in which you belong to. Thank you very much, Ashraf.
Thank you very much. That is Segi Pillay, the representative of the Wits Health Consortium, who is in partnership with the NIH with the support of the Health and Welfare HWSETA. So I'm just quickly going to share with you a slide to advise you that those who are registered with a professional body, and that is in good standing with your own professional body, the ones that are listed there in the middle of the screen, the Health Professional Council of Africa, South African Institute of Occupational Hygiene, South African Dental Association, South African Society, South African Institute of Occupational Safety and Health, and the Stelmed through the medical faculty of the Stellenbosch University that deals with the occupational nursing practitioners. We have not yet secured accreditation from all bodies, but those are the ones where approved points are provided. Once the session is done, you will receive an email with a link and a password, but that is not for people who don't belong to a professional body. Please, this is only for those colleagues who are registered and in good standing with your own professional body as listed on the screen. And right at the bottom in the line, as Segi indicated, for certificates of attendance, that is administered by our colleagues at the Wits Health Consortium, and the email address you'll see at the bottom there is hwstraining@witshealth.co.za. That's hwstraining@witshealth.co.za. If you have any questions with regard to certificates of attendance, I will take responsibility here by the NIH for the CPD related aspects, and you can always email us if you have questions at info@nioh.ac.za. That's info@nioh.ac.za. So thank you very much for that, Glenn. We're going to move on with our program. We are slightly behind, and we've had to just quickly swap our speakers because of just sorting out some technical aspects. The first speaker is the experiences of occupational health nurse, and that's Ms. Kim Davies, who is a member and representative of the South African Society of Occupational Health Nursing, SASON, with an OHN at the end. The speaker that follows is going to be the Dr. Lesego Rametsi. The experiences in the banking industry will be dealt with by Dr. Rametsi. And then we will have the experiences in the mining industry by Dr. Irene Mampa. And Dr. Mampa, she will deal with sharing the experiences in that particular sector, who's also been quite challenged with the risks that they are facing. So I'm now going to just immediately go over and ask if Kim Davies, Ms. Davies, are you online? Can you just unmute yourself?
Yes, I am.
Thank you very much for availing yourself and willing to share your experiences with the NIH's or stakeholders and audience to ensure that we can make our workplaces safer and healthier places in the unusual and difficult circumstances. Will you be sharing your presentation?
Yes, I will.
Okay, so I'm not sure if I have a bio for you, but what I do know is that you are an active member and representative of the South African Society of Occupational Hygiene. And I see on the screen there, past president. So if you want to add anything in introduction, please do so. Thank you very much. If you could just maximize your presentation and proceed. Thank you.
Thank you very much for this opportunity to share with you a little bit. Yes, I'm a past president of SASON, the Society for Occupational Health Nurses, and I think that these webinars have actually been excellent within the time frame, and we've actually learned quite a lot from it. So I will then carry on with my presentation. My scope: I will be looking at the management of persons under investigation, the screening tool that is used in an industry where I work, so it can either be used for state or for the private industry, a little bit about vulnerable workers, the quarantine and isolation facilities, staying or working from home, and then challenges. So the management of a suspected person differs from a state and can also differ from province to province. We must also be aware of a differential diagnosis before we just say that the person is COVID positive. We also need to look at seasonal flu, conventional and atypical pneumonia. People can also suffer from that, or the non-infectious causes of dyspnea and or fever related to a pulmonary embolus or myocardial infarction, as well as heart failure. So as you can see that there is a variety of examinations that we can do before we just make the diagnosis. Within most of the industries at the moment, screening is done before and at the end of shift. If the screening is done before shift and the person has a high temperature, they are normally put one side. In my organization, we are taken to a separate area where the person is then seated. A questionnaire is filled in, and then we would proceed to either take him to a sick bay or a facility where we can then proceed with examinations further. A little bit about the screening tool that we use at the moment. As you can see, we have the personal information, which we can then also use for contact tracing. This is filled in by everybody that actually enters the property, whether it is a contractor, a visitor, or of the health professional people, or even just workers coming into work. So we have a variety of questions that we have asked, and recently we have also added the attendance of funeral, because we have found that most have been people that have attended funerals within the last week or within the period. So that is one of the questions that we have added. Actually detect, or if we need to refer people to, and then we also then interpret it through the people that are actually doing the screening, which is then placed in a file. So if we then need to do contact tracing, it is so much easier to contact the people and we have the information at hand. Further management is early detection. I think that that is one of the key areas within the environment in which we work, especially in industry, whereby sometimes the people cannot be isolated. So early detection is actually, I think, in the forefront of it. We also have communication through posters, billboards, pamphlets, and just communication sessions with people on an ongoing basis throughout the day and throughout the screening. All members are screened, as I have been said. We normally do a temperature screening, and if the people's temperature is a bit high, we then have them sit, and we also can do body temperature screening if it needs to be done. If there is a suspected case, obviously they are not even entered into the work area. They are placed in a separate area. In a lot of occupational health areas where a sick bay or a medical facility is in hand, the members are then taken there on a consultation basis, and there's normally only one or two people in the area to protect the workers as well as the health professional person that is supposed to see them. We then ensure that they have masks on, and hand sanitizing and washing is obviously at the forefront, because that is one of the ways that we can protect the healthcare workers and the workers. Isolation rooms, if they are available, that workers should sit there and wait to be seen, or if we need to recheck them for their temperature and do further management or interventions, that is the place to be at. I think health education within this sector is absolutely of paramount importance. I think even though there is so much information available, people need to be educated on the virus, how to identify the signs and symptoms, looking after them with their protective clothing before they even go home, how they should handle getting undressed at home before they go into the house, to look at the families, because even though we are in the working environment, I think it is very important to also protect our loved ones at home. Rapid transfer to a health facility if required, if the member deteriorates, or if we feel that due to the disease profile we need to have further investigations. Obviously we will then transfer them. And which is very important is telephonic follow-ups. I think that this is one of the things that we really and truly need to look at, is to support the people when we have a suspected case and we have transferred them. The vulnerable workers, I think quite a lot has already been said about vulnerable workers, but this is also something in the occupational health setting with regards to the multidisciplinary team, which is very important to actually look at the workplace risk assessment and see where we can do accommodation for the workers that are vulnerable, where we can place them in an area that would suit them as well as the workplace. The work evaluation in terms of the workplace and vulnerable workers, to see we have some members within the working environment that are already 60 years and older. But if they are stable, they are on their medication and we can accommodate them, we really and truly do so, as a lot of workers cannot work from home. So we need to accommodate them in an area within the working environment that is safe for all. Through the screening process, we can also do contact tracing. That is an invaluable tool if we have anybody that is positive, and we should do contact tracing and follow up. Then obviously workplace policies and procedures are important. If members are working from home and they need to be placed on a system, we need to follow the procedures and the policies. I know some of the workplace policies have been updated to accommodate members working from home as well as the vulnerable workers, and this should be updated with the new information that we get. As you can see, this is just one of the assessments that could be used with regards to vulnerable workers, and I think that quite a lot has already been said about it. A lot of workers feel that they do want to work, and at the moment we are really and truly looking at accommodation for those members that we feel can. And if you look at the health sector, within some of the sectors and the people that we have requested to come back in the working environment, especially of the nursing sisters, we do find that a lot of them are 60 years and older, and we need to look after them within the workplace as well. A lot of members are stable on their medication and can do an invaluable service within the clinics by, identifying, not being at that high risk, but at least assisting with follow-ups and actually phoning up the people to see whether or not they are fine. Return to work, we do a medical evaluation to see whether or not they're fit to return to work. By saying this is we have an interview with all the members to see how they are coping, what are the vulnerabilities that they are suffering from now, whether or not the temperatures are fine, and then see whether or not the work that they were doing can still accommodate them once they are back at work. We also do social distancing to really and truly try and see whether or not within like the HR environment, where a lot of members are sitting and doing statistics, doing the leave, and just to see that we look after them. The restrict adherence to hygiene, extra wash basins have been put in place, and I think that in industry, especially where you are on the shop floor, that this is something that we should look at. There are hand sanitizers all over the place, and with the self-monitoring, I think it is important that we really and truly look at the members and through health education to just make them aware that they know the signs and symptoms and when to seek medical advice if these symptoms worsen, or if they are just worried, where to go to, who to phone to, and then for follow-up if necessary. Isolation facilities, I think that the government is busy working on that. I know quite a lot of private institutions are also looking at facilities whereby you reduce the transmission. If we look at some of our workers where they live in conditions where there's more than one family or more than 10 members within the family, where can they isolate safely to reduce the transmission? So we are suggesting that it is not in a confined area, that they try and see that they have a separate room or a separate facility that they could go to. We also try and see if it's near a medical facility or institution, whereby if the signs and symptoms worsen, that they are easily transportable and that they can seek medical attention. Ensure disaster management and evacuation plans to know the best route, where to go to, who to phone, and basically if something does happen, that they can get to the medical facility fast enough. We're also looking at laundry. I think laundry facilities are quite important fire as we are going through winter, and some of these facilities are in areas where firefighting is not always that readily available, but to look at how they can adjust within their environments, if there are fire stoves or if there is a cardboard or something that we look at that. We also saying about ablutions. There should be enough ablution facilities. We are looking at housekeeping and food services within these areas, due to the fact that we have to look at quite a number of members within this area, and we are trying to look at food services that can give takeaways. We really truly need to look at the waste management of this, because I think that this is something that we really and truly can escalate quite fast and not necessarily something that we have looked at. Quarantine facilities, people or groups who are asymptomatics but have been infected with COVID, we really and truly need to place them in an area where we can keep an eye on them. Should any of the symptoms obviously deteriorate, that we can then send them to a facility that could accommodate them. We're looking at people in close contact with other infected people so that we can minimize that and ensure that everybody that is in the area is safe, as well as with the medical personnel. High risk of exposure during international travel. So far, I know that there has been some travel, but quite a lot of our members that have been coming back have been in isolation, just to ensure that they are looked after and that they do not expose other people when they are back at work, and that the work can continue. We're also looking at asymptomatic people awaiting testing. I know that quite a lot of people that are asymptomatic are not tested, but those that then develop the symptoms are tested, so that we are ensuring that we then know the status of the people. There is quite a lot of stigmatization with regards to people that then go for testing, and I think that that is one of the areas whereby the whole multidisciplinary team can come in and really and truly give information through to of the workers, that those people that do have the symptoms and have tested, that they are then accepted back into the working area once they return to work. This is just a picture that I got of some of the facilities whereby people can isolate, where they do have access then to the bathrooms, and an area whereby they can actually just relax, read a book, and just see that we keep them safe. It's normally people awaiting results. Some healthcare workers that are asymptomatic but following exposure, we are looking at their health profile to see whether or not they are safe to then return to work. And also we need to look at the air crews that are flying people back on the repatriation flights, whereby we just monitor them for a period to see whether or not they are safe as well. Working from home, I know that there are some jobs that cannot work from home, but as far as possible, we recommend, and in our working environment, as far as possible, we recommend 50-50, so that we have got 2 shifts, that in case something happens to one shift, that the other shift can still participate and do the work within the environment. Not all jobs can be done from home, as I've said, and if we look at the forklift drivers within industry, it is very difficult. Salespeople, for example, the brick makers, those people that are driving around the heavy duty trucks, so those people cannot work from home. Those are the people that we really need to monitor and keep safe within an area, and phone them. Private companies, if there's no work, there's no pay, although I know with the accommodation, quite a lot has been done within this environment. For example, if the people cannot work from home, then we have 2 shifts. They can either come in the morning, do what they need to do so that they are at work for a portion of the day so that they can still get the salaries, and then we accommodate them by going home in the afternoon so that we can lessen their exposure time at work. We also look at the UIF or the TERS claims that we can then request additional funds for these members if they are not at work all the time. Challenges, I think that is in every industry and all over, are limited equipment and human resource equipment. I think that this is really limiting, especially if you look within the hospital setting, as well as with the healthcare providers. At this stage, it is an absolute golden resource which we do not have enough of. Although if you look at what all the healthcare workers have achieved so far, I think that they have really and truly outdone themselves. And that is why it's so important within this day and age with regards to occupational health, where the medical team, the doctor, the hygienist, the occupational health nurse actually are working so close together within this pandemic to alleviate and assist one another. There are not enough, sadly, facilities where people can isolate, and that is something that I think that each industry really needs to take to heart and look at, that we can try and alleviate this. The psychosocial strain on people, even in my environment, I have found that people are really worried. They don't always know where to go. Even in this day and age whereby there's so much information on the internet, they can Google it. I still feel that people have to have some sort of workshop where they have health education, where somebody just phones and speaks to them, where they can actually go to if they do have worries. The emotional strain on some of the families are quite great. I think we still don't know enough about the pandemic and how it affects us, even with all the research that is coming through. So we have got a very good psychosocial team. We've got a social worker that is there constantly, a psychologist, and the whole professional team also sits on Skype, as we are doing now, or Zoom, to really chat to each other about how we can mitigate some of the patients that have come through, or some of the workers that are in dire straits. The economical strain on people, we have found even in the state and in some private facilities whereby only one member works, it is really taking quite a big strain on people within the working environment. So we are promoting people that can work, they should come through to work. The implementation of guidelines, regulations by different occupational health practitioners, the HR personnel, really need to be looked at, that we speak from one voice and that all the information goes out. Employees lying about asymptomatic to be able to work from home. This, unfortunately, is a huge problem, especially in some of the public sectors. And that is why it is so important sometimes to have a one-on-one with the employee and to have a system whereby you actually go through the signs and symptoms and you actually chat to them. Because what we have found in our industry, not everybody understands what they are supposed to answer or what they are supposed to say if they may be feeling ill with like a cold, and if they are traveling with the taxis or from Johannesburg to Pretoria. So that is really and truly something that we need to look at and be vigilant of. The non-compliance to PPE, social distancing and hand washing, that is something that we try and mitigate within the working environment. I know in some areas PPE is limited, and we need to really and truly look after the resources that we have. There has been incidents where there's been non-compliance to regulations, and I think that this is all over, not only in the public sector, but in the private sector. And again, I think that that is something that we need to look at with the health education, which we are encouraging everybody within industry to do. And like I've said, anxiety and fear amongst employees, and obviously they talk amongst themselves, and that through the alleviation thereof is really and truly to look at health education once again, to make sure that we explain to the employees in a language that they can understand what the virus is, what they need to look at, and where they can go to. Thank you very much.
Thank you very much for that. That was Ms. Kim Davies from the South African Society for Occupational Health Nurses, SASON, on the experience of occupational health nurses. I think a critical contributor within the occupational health professionals with the occupational medical practitioners, they are the occupational health nursing practitioners. Thank you for that, Kim. Our next presenter is Dr. Lesego Rametsi. Just to check if Dr. Rametsi is online, can you unmute, please? Can you just check?
I have unmuted. Good morning. Thank you very much.
Thank you very much. If you could just share your presentation. And whilst you do that, a brief introduction. Dr. Rametsi is in the finance and banking sector. She's a qualified medical doctor with a postgraduate qualification in occupational medicine and an MBA, both obtained from the University of Cape Town. She's currently the group head of health and wellness at Absa Bank and a key player at the forefront of the bank's multidisciplinary task team coordinating the bank's response to the COVID-19 pandemic. Dr. Rametsi, or Doc as she is fondly referred to, has extensive experience in occupational health, workplace wellness programs, health risk management, comprehensive health strategy and sustainable development, cutting across the mining and resources industry and the banking sector. Dr. Rametsi is an avid advocate of health and holistic living and well-being across all wellness dimensions. And then finally, a sought-after corporate wellness and women's health speaker, Dr. Lesego has served on various advisory committees informing policy on occupational health, TB, and HIV. Dr. Rametsi currently serves on the Bank Med board as an employer-appointed trustee member. Dr. Rametsi, thank you very much for making time to join us today and share your experiences with the audience and the NIH stakeholders. Please proceed. Thank you.
Good morning. Thank you very much for that introduction. So today I'll just be covering our approach from an ABSA point of view on how we manage persons under investigation. Just to give a brief overview, I think all of you are familiar with ABSA. ABSA is a financial services company. We operate mainly in South Africa and 10 other African countries. Today's presentation will be focused on the South African operations, where we have 32,000 employees. We have an extensive retail branch network, which is, I think, a pride for ABSA operations.
How many employees? 32,000?
32,000, yes. Extensive national footprint. I think in every small town in this country, you will find an ABSA branch. And in addition, we have call centers, which are customer service centers. So if you lose your card or you need to reset your PIN, you call a number, and that's supported by a huge human resource in those service centers. And we also have corporate functions from your information technology, finance, legal, HR, marketing, corporate relations, you name it. And that's really the back office that supports the operations. And pre-lockdown, you can understand that we had a very huge component of our workforce working from the retail outlets, call centers, and corporate functions sitting in our head office, which is in the Johannesburg City Center. But during the lockdown, you will appreciate that even under level 5, the banking sector was identified as an essential service. So we had to remain operational during level 5. And what really this has done for us as an organization, it accelerated our digital journey, as in we really had to make sure that as many of our processes can be done remotely through our digital platforms. And this has allowed us to have 60% of our workforce working remotely. So our outlook has always been that which can be done remotely should be done remotely. And we now only have 40% of our workforce working in our offices because they have to service clients. This is at our outlets. And in addition, some of our systems do not allow for remote working as yet, but there's a lot of work in the background to ensure that as many of our colleagues can work remotely. So how we manage persons under investigation, we look at the risk stratification process to make sure that those that are at high risk do not arrive at work. Those with medium risk are assessed as soon as possible. And those that are of, if you're identified as having symptoms at work, we have to be in a position where we can identify you as quickly as possible, isolate, and make sure that you get the necessary help. So we look at 3 tiers of prevention. So the first one is primary prevention, where we prevent symptomatic persons or persons under investigation arriving at work. And then secondary prevention is around preventing symptomatic persons from interacting with other colleagues. And then we have a tertiary prevention where we do isolation, rapid response, and evacuation. So from a primary prevention point of view, we spend a lot of time around education and awareness to make sure that all of our employees are au fait with COVID-19 related symptoms. And in addition, we have implemented the return to work questionnaire, which was a once-off questionnaire, and we will continue to roll this out as more colleagues return to the office. And we also have introduced a daily self-screening questionnaire. From a secondary prevention point of view, sorry, can you go back to the previous slide? Sorry, I'm not navigating my slides because Zoom, I do not have full functionality of Zoom on my machine because of security from the organization. Thank you. So from a secondary prevention point of view, we look at how best we can prevent symptomatic persons from interacting with other colleagues. So if when you do your return to work questionnaire or your self-screening questionnaire, you are deemed not fit to proceed to the office, we have established a COVID-19 hotline, which is manned by nurses and doctors where employees would call in. So I'll just go into the process just now when we go to the next steps. And in instances where a colleague is deemed unfit to return to work or unfit to return to the office, we deactivate the access control up until they have supplied us with a medical clearance certificate. And with regards to tertiary prevention, this is really for those that develop symptoms whilst at work, or if when you come in, you have a raised temperature due to thermal screening, we make sure that immediately you are referred to the on-site clinic so that your temperature can be verified. And if indeed it is raised, you will be referred for medical assistance. but if it's a false positive, then you will be cleared by the on-site nurse. So tertiary prevention is really around isolating and making sure that we respond as rapidly as possible to make sure that we minimize the transmission of infection in the workplace. Next slide, thank you. So how the return to work questionnaire is, when we moved from level 5 to level 4, we had to introduce quite a lot of activities back into our service offerings. So with that, we asked all colleagues that were identified as those that are returning to do a return to work questionnaire. And this was deployed via technology, where colleagues could access this via SMS or MMS and WhatsApp. And there they were asked to answer these following questions. The first one is, have you been diagnosed with COVID-19 in the past 14 days? Have you been in contact with a suspected or a confirmed case of COVID-19? Are any of your family members currently in self-quarantine? Are any of your family members currently in self-isolation? Are any of your family members or you awaiting results for COVID-19, or do you currently have flu-like symptoms? So if you answer yes to any of those questions, you are immediately asked to inform your line manager and call the COVID hotline, which I alluded to, where you are given advice on what the next steps would be. So if, for an example, you have been in contact with a confirmed case, then the advice would be self-quarantine for 14 days. If you are awaiting your results, we get follow-up to see when the results will be available. And if you test positive, then the self-isolation guidelines will be followed. If you test negative, then you will be cleared to return to work. So each case will be treated on its own merit. And to my earlier point, if you are not cleared to return to work, your access control will be deactivated immediately to make sure that only colleagues that are fit to return to work. And you will see it's a very easy system that we use. We use your login details that you use to log into APSA systems. And thereafter, it takes you to the questionnaire. You do an attestation, yes or no, and you click, it's one click where it's submitted. And each line manager at any point in time would have line of sight of the number of employees that report into them, how many of those have completed the return to work, and how many have been cleared to return to work, and how many have not been cleared to return to work. And this is also quite, it assists also with planning, workforce planning. If you have 10 direct reports that were meant to return to work, and 8 of which are fit and 2 are not fit, it gives you time to look for additional resources if the need so arises. We can move to the next slide. Thank you. So the daily self-screening questionnaire is something that we introduced in line with the occupational health and safety regulations that requires the workplace to ensure that each employee on a daily basis completes the self-screening. And even with this one, we've introduced a digital solution where colleagues are expected to do this on a daily basis, and they have to do this before they even leave home to ensure that those that answer yes to any of these questions do not proceed to the office. So you have to answer yes or no. Do you have cough, shortness of breath, fever or chills, sore or scratchy throat, muscle aches and pain, and all those symptoms associated with COVID-19. And if an employee answers yes to any of those questions, then they are deemed unfit to return to work. And what is required of them is that they have to, I think we can move to the next slide. There's a next slide that will show the process quite, the next one, thank you, quite clearly. We can move to the next one. Okay, so how it works is every morning a colleague is expected, an employee is expected to complete this questionnaire. And if they answer no to all the questions, then they can proceed to work and ensure that they wear their face mask at all times. And when they arrive at their buildings, the thermal screening protocol will kick in. And if the temperature is normal, they will be, they can proceed, into the workplace. If it's not normal, they are referred to the on-site clinic where the temperature will be checked. And if it's a false negative, a false positive, then they are cleared to return. If they do have fever, they have to seek medical assistance. So if you answer yes to any of the questions, it's clear you do not go to the office. You have to call the hotline that I alluded to. And as part of the triage process, the medical professionals that man our hotline will do a secondary screening to establish, if the symptoms, the severity, and also if any testing is indicated. So if, for an example, somebody has a runny nose and it's because they have chronic sinusitis, based on that assessment, they can be cleared to return to work. If they're medically unfit, they are then advised to seek medical assistance, provide a sick note as per normal processes, and they can only return to work once they've been cleared by their medical professional. Next slide, thank you. Okay, so what do we do if an employee exhibits symptoms whilst at work? So what is important is they have to notify the people manager or line manager immediately. And in instances where we have, in the bigger corporate sites where we have a clinic, the employee would go to the clinic and they will be isolated in a designated boardroom if we do not have a clinic. And as part of the process, we ask them to start listing, all employees that they were in contact with in the workplace. And our close contact definition is aligned to the Department of Health definition. And once that list is complete, the colleague will be referred to the medical professional who will then do the necessary assessments. And if there's a need for them to get tested, they will be tested. And depending on the outcome of that test, if the person is negative, they will be cleared to return to work. But if they are positive, then they will be treated like, our protocols as per the management of a person that's confirmed COVID-19 positive. Next slide. And the same process, it's the same for those that are away from the workplace. But what is important is if you exhibit symptoms whilst you're not at the workplace, it's important that you do not proceed to the office and you should seek medical assistance immediately. And in addition, you have to notify your line manager and provide them with the list of all the close contacts in case you do test positive. If your symptoms are such that after the assessment, your doctor establishes that you need to get tested, that testing will be done. If you're negative, you will get a clearance letter. And if you're positive, you will be managed as per the positive COVID-19 protocol. All right, next slide, please. So this is how we managed employees that are COVID-19 positive. They have to immediately log their case with the hotline and inform their line manager. They will be treated as per the clinical guidance by their own doctors, and they will be booked off, and that they'll record absence on our HR system. In addition, they'll provide a list of all the close contacts that they were in contact with, and all work-related close contacts will be followed up by a hotline, and all those colleagues will be asked to go into self-quarantine for 14 days and self-monitor for symptoms. Those that develop symptoms will get tested, but if they do not develop symptoms, then they have to complete their 14 days of self-quarantine. In addition, all our employees that test positive for COVID-19 get a proactive call from our hotline on day 5 and day 12, just to check in with employees to see how they're doing and provide additional medical support. And after the 14 days self-isolation, then they can be cleared to return to work. And in keeping with the Department of Health protocols, we do not ask colleagues to be retested before they return to work. If they are asymptomatic and the doctor is of the view that they are fit to return to work, they will return to work. We're currently reviewing this guideline based on the presentation that was shared by Dr. Buthelezi during this past week, where there's a new recommendation for self-isolation to be 8 days. So we're reviewing that, and it's possible that we will align to the new guideline going forward. Next slide. So what we do, our self-isolation, we have our approach is aligned with the Department of Health guidelines. For those that can self-isolate at home, we encourage that. And for those that cannot self-isolate at home, 100% of our employees belong to a medical scheme, BankMed, and BankMed has negotiated with a few suppliers for their members to self-isolate at appropriate facilities. So that is also available. So for all employees that are unable to self-isolate at home, there are isolation facilities that are available. But in addition, we give all our employees these guidelines on how to self-isolate safely at home. Next slide. Okay, thank you. So yeah, I hope I've made up a bit of time. And if there are any questions, I'll take them towards the end. Thank you so much for your time and for your attention.
Thank you very much. That's Dr. Lesego Rametsi, the head of occupational health at the ABSA. So thank you for that. That was, and just to say, I told my colleagues while you were busy that I loved your decision trees, and I hope that our participants and our stakeholders, today's attendees, would find that useful as well in their own workplaces. Our next speaker is Dr. Irene Mampa, that is from Impala Platinum, who's going to share with us the experiences in the mining industry. Dr. Mampa, are you online? Can you unmute yourself? Or you are unmuted? Yes.
Yes, I have unmuted. Good morning, everybody.
Good morning. Please share your presentation.
Thank you. Before I start the presentation, I would like to give you an overview of Impala Mine in Rustenburg. We are currently catering for 57,000 lives. Our employee number is 42,000 employees. Why 57 lives is because we have also dependents, which are the wives and the children of employees who are on the medical aid. We also cater for about 800 pensioners on the medical aid. So it is quite a vast number of people that we cater for. I'm going to move on to the next slide. This is quite a busy slide, but this is all our thoughts heads put into it, the clinical manager, the occupational manager, and also safety people, including HR. I'm going to present this slide in different mode. Okay. Next slide. I'm going to first start with the slide of the people coming from the labor sending areas, which is the yellow portion on the big screen. Excuse me for that. We have arrangements with TEBA, which caters for our employees with chronic diseases. Before we fetch these people from the labor sending areas, the arrangement with TEBA was that TEBA will do our screening for these employees at the labor sending areas. The screening of COVID, which is the same questionnaire that we use at the mine, was of the symptoms of COVID, and also it included questions as to whether this employee has somebody at home who has been ill with COVID, or they have been in a taxi transit, where they were contacted by the Department of Health to assess whether or not that there was somebody that they were traveling with who was a contact, who was coughing and had been diagnosed with COVID. These nurses will then assess the individual. If it is positive that this individual has symptoms, they will then be referred to the clinic, where in the labor sending areas where they will find treatment. If this individual does not have any symptoms, the TEBA will then contact HR offices at Impala and find out whether this individual has been requested to come back. Initially, what Impala did was to arrange transport, basically to go and fetch these people from the labor sending areas. But what we then found was that we had trouble with the local people. They said that, no, we cannot arrange, you cannot arrange your own transport. We would like you to use our taxis. So we had negotiations with the taxi association at the Eastern Cape, at the labor sending area, and they were able to assist us to bring our individuals to Impala, employees to Impala, where they will then resume work. From there, when they arrive in the Northwest Province, the labor sending areas, together with the employees from the labor sending areas, they will initially arrive at the shafts. At the shafts, outside the shafts, there will be the HR who will then basically ask them a questionnaire and divide these employees. You are coming from the labor sending areas, and you are the Northwest people. The people that are coming from the labor sending areas will then be transported to a central area, which was the visitor center, where they will be then transported to the hospital. The people that are coming from the Northwest Province will then be screened at the shaft. The screening will include a questionnaire. The questionnaire will include the same questions of COVID, which I spoke about, and they will also have a temperature screening. If the individual is found to have a high temperature or have symptoms of COVID, this individual will be placed in an isolation room. The nurses will then inform a center, which we call the COVID help desk. At the COVID help desk, there is a nurse, an HR. The nurse will then call into the hospital and inform the hospital that there are COVID suspects at the shaft. Can you please engage our EMS services to go and fetch the people? The people that are at the visitor center, the people coming from the labor sending areas, will then be brought through to the hospital through the COVID help desk. They will then be referred through to the current room, which we call room 5 and 6, where they will then be assessed for symptoms, and they will actually, at the beginning, we tested them. We will then, the people coming from the labor sending areas, we will then admit them into our Maharing quarantine facilities after they had been assessed, and they will be monitored daily by the doctor and the nurses at the Maharing quarantine facilities. The people that come from the shaft who are symptomatic will then be referred to an area which we have identified, which was the room that we use for physiotherapy. We call it physio, where there will be a doctor and nurses that will evaluate the symptoms of this individual and do a test to assess whether, if they have symptoms, they will then be tested. The symptomatic people in the hospital, when they are tested, they will then, the doctor and the nurses will assess and ask the employee a home quarantine or isolation questionnaire. Now, this home quarantine or isolation questionnaire has questions like, are you able to isolate yourself at home in a bathroom, with a separate bathroom and a separate bedroom? Are there no elderly people with comorbid conditions at home that you are staying with? So basically, the initial questionnaire that they're asking is to ascertain whether that individual will be able to quarantine at home whilst they're still awaiting their results. If the individual says yes to all those other questions that they will also be able to cater for themselves, that individual will be sent home for home quarantine. Then we have what we call the contact tracing team. We will then move to the contact tracing team, where the contact tracing team receives results from empath daily at 9 o'clock, 12 o'clock, or at 1500 hours. These results, if they are positive, HR will be notified. HR will then proceed and identify the work contact. The work contacts will then be brought to our room 5 and 6. The tracing team will then go into the community to where this individual stays. And when they arrive there, and they will find out, they will assess the household conditions for that particular individual who is positive. So the individual was on home quarantine, and then they found that the test is positive. The tracing team will then go to the household of that individual who is at home quarantine and is placed on sick leave. They will then assess the household, as I informed you before, to see whether it is suitable. If the household is not suitable, that individual will be brought into our Maharing isolation facilities. If the household is suitable, they will then continue and proceed to assess the current medical condition of that individual. They will assess for comorbid conditions, and if the individual is symptomatic, they will then refer the individual into our isolation facilities in the hospital at Maharing isolation facilities. If the individual is not symptomatic, is asymptomatic, he will then continue to stay home. The contact tracing team will monitor, will ask the individual if they're on any other chronic medication. If they're diabetic, they will then be admitted into the hospital. If they are hypertensive, they will then monitor their BP, pulse, and saturation. If they are stable, and they will ask them if they have chronic medication available, they will then leave the individual at home. Follow-up of these people that are on home quarantine and on home isolation. Daily monitoring through telephonic calls is done. And the telephonic calls that are done is to assess the individual to find out whether are they symptomatic or asymptomatic. If the individual is symptomatic, the contact tracing team will go and visit the house, the home of the individual, where they will assess the condition of the individual. If the individual is symptomatic, but is not severely ill and has no comorbid disorders, they will then continue to leave the individual at home. They will issue a flu pack to the individual which contains vitamin D and vitamin C and zinc. But if the individual is in a state that they are severely ill and they cannot be left at home, they will then refer the individual to our Maharing isolation facilities. Now, it depends on the symptoms. If they're mildly symptomatic, they go to Maharing isolation facilities. If they have moderate and severe symptoms, they will then be referred into our hospital isolation facilities. If when in the Maharing isolation, where they are monitored daily by a doctor and a group of nurses, if their conditions deteriorate and their saturation drops between 90 and 95, they will be referred for admission into the hospital for isolation. If in isolation, in the hospital isolation, where the doctor is treating the individual, if the individuals require treatment through CPAP or any support, oxygen support, the doctor will proceed and treat the patient. If it comes to a point where the doctor sees no, this patient requires referral to ICU, the patient will be referred to our ICU, preferred provider hospitals at Fancrest and at Pegleray Hospital. Now, this is a diagram I think we are all familiar with. We have seen it from the NICD, just showing us the nasopharyngeal test and the oral swab that we do for the PCR test for corona. This test is done by our doctors. Our nurses on the ground are taught how to do the test. Now, what did we also do for our employees? Now, at OHC, we identified all vulnerable employees. We assessed whether their fitness category meaning if they're diabetic, they have certain restrictions. If they're epileptic, they have certain restrictions. We then educated and targeted all our vulnerable employees. These are our chronic patients, the diabetics and the hypertensives on COVID, that they must be aware of the symptoms. And this was done earlier onwards in January. We issued immune boosting. We did an influenza vaccine. We also gave vitamin C. Initially, even before the lockdown, we started by issuing our employees with chronic medication, and we tracked them and blocked those that were defaulting, and then we referred them to the hospital and clinics where they were assessed by our doctors and given 6 monthly scripts and monitored to ensure that they are well controlled. We went back and we did data mining to assess the people that are actually at work, whom of these are at high risk and the type of work that they are doing. We then also proceeded, as I spoke, at every shaft. Before entering any shaft, there's a screening point where the individual will be screened. We also have what we call a medical declaration form that the employee will not enter any shaft if they find out that they've got symptoms. They will, however, inform their line manager of the symptoms, and then the line manager will advise them to go to the hospital or clinic where they will then be assessed for COVID as PUIs. Just as to continue, on the clinical markers of severity of disease, we assess how many of our employees are greater than 60 years. We also looked at the range of the percentages at where the death rate increases per age. We also did the diabetes and hypertension and assessed whether we have capacity for oxygen, that we will be able to treat our employees in the hospital when they require oxygen. We also have employees whose BMI is greater than 30, whom we assessed and made sure that we assess whether they don't have any comorbid conditions. This were checked by our occupational medical practitioners, and those employees that were greater than 60 years with comorbid conditions were declared unfit to go back to work. We then also moved forward to change our COVID PCR testing protocols to test only those that were symptomatic, 50 years with comorbid disorders, and all ages with poorly controlled comorbidities. As I spoke about, we have vulnerable employees, some in home quarantine, isolation, and some in the hospital. I'm going to move from this slide. We all know about the flattening of the curve, that if we don't flatten the curve, if we don't have measures where we ensure that we can accommodate all our people in the healthcare system, and we don't assess these individuals early enough and efficiently so that we make sure that we identify all those with COVID, we will peak at a certain level. However, we continue to make sure that our health facilities, by organizing quarantine isolation facilities, and also oxygen pods in the hospital where we can monitor our individuals. What we also did is we went and used the actuary science South African model, and we applied it to Impala with its employees. And we put the number there for 40,000 employees, where would be our percentage of population peak for scenario 1 and scenario 2, and the peak number of infections for symptomatic people. At scenario 1 is 397, scenario 2, 1,555, and also we assess the capacity as to whether we will be able to accommodate these people at the different scenarios, saying that if it is in scenario 1, we need 54 beds, scenario 2, we need 84 beds. And then from there, we looked at the deaths and said scenario 1 will have 33 deaths, scenario 2 will have 59 deaths. Currently, we are sitting at the peak number of infections. You will see in my next slide. We are at 1,218, but however, we have around 7 deaths. Now, when we looked at these curves, this is at Impala, number of infections per week. If we didn't do any intervention, we will be sitting on the red peak. But however, Impala is sitting on the blue peak, and also the number of people that are hospitalized with the time frame, you can see on the blue peak, on the blue line, that we are actually not picking up. And if we didn't do any intervention, we would actually have a peak. If we look at the cumulative deaths, we are sitting at 7 deaths, and we actually have not reached 100 deaths currently. When we look at the positive cases, the total positive cases, we can see that we have 7 deceased, but we have recovered around 798 with a total of 1,255 cases as of yesterday. We can see also that we have active cases, which are 450. What we then did was we realized that we have quarantined all our employees. We tested them, they were negative, and we admitted them in our our quarantine facilities and released them to the community. But however, we realized through the testing and also identifying in geographic position where our shafts were, we realized most of our employees, they actually stay in the community. And it seems like the employees that are presenting with the symptoms are actually coming from our local community. We seem to be testing internally. Our numbers, we have it under control, but when we release our employees to the community, most of them come back and now they are positive. So we were trying to find out, we probably have hotspots in the communities where these individuals are staying. So what we then did is we engaged with the Northwest Government, Department of Health, and we said to them, can we please test the community where we have identified per shaft that these are our hotspots. So we tested actually the community in Bujanala, which goes to Job Shimangani Hospital, and we found that 29% of the people were actually positive. We then went to Freedom Park, which is adjacent to some of our shaft 10, 11, and 16, where we were picking initially, and we realized that 12%, we only did 93 tests, but 12% of those people were positive. We are still continuing to test together with the government. But you can see with the green that the number is actually going higher. The yellow is our dependents and applicants, and the blue is our employees. When we look at our shafts, our initial shaft that was bothering us the most was shaft 10, because that is where the peak was high. And then 11 shafts, 10 shafts, 11 shafts, and 16 shafts are actually in the same area, whereas 14 shafts is next to, it's basically towards Sun City, and it is in a different area in Luka. And at Luka, we found out that there was 45% of people that they were actually positive that were coming from the community. But when we looked at the different shafts and areas where our employees are working, we realized that the people in services, and the people in services are actually the ones that are working on service, they are working in offices, they are working as boiler makers, and majority of them have comorbid disorders. We realized that that is where we had a problem with the infection. And of those people, the blue one is isolation, the orange one is quarantine, and we can see that in services, and it is where we have most of our comorbid disorders, diabetes and hypertension. Most of them we admitted in high care and in ICU. If we look at the total number of employees in service per age, you can see that the ages between 35 and 39 is 7,000 employees, but then the risk categories is between 50 and 54, which is 5,242, and then 55 and 59 is 4,000, and 60 and older is 1,000. Currently, most of our deaths, we have only 7. The people are in the age ranges between 50 and 59. And then if we look at the total cases that were positive per group, we can also see that if you look at the ages of 40 and 44, we have 216, and 35 and 39. These ages in this category, the individuals are actually alive. But if you look at the age of 50 and 54, the employees, the 7 individuals that died come from this category, the 172. And of the 60 year old that are positive is 29 of them, and we have not yet had a death from a 60-year-old. If we look at the age group per split, we can see of the 60-year-old is 29 out of 1,000, and of the 50 to 54 is 172 out of the 5,000 odd. If you look at the total recoveries per age group, you can see that in the cases, the total cases, the blue, and the total recoveries on the age groups of 50 to 59, there's still some active there. It's 198, and then of the ages of 60 to 62, we have 16 that are recovered. These 2 X-rays are just to show you the type of patients that we get who have corona. Most of them, when they arrive already, some of them, their saturations are at 60%. We then could proceed and put them on CPAP. And you can actually see on the X-ray, the first one, the one on your left, it looks like a bat wing appearance, as if this individual had pulmonary edema. This individual was a lady. She was 42 years old. She was admitted into ICU. She had thyroid disease and HIV, and she is alive today. The X-ray on your right, this individual was a 58-year-old male, known diabetic, who was transferred to our ICUs, but unfortunately, we lost him. He died in ICU. He didn't do so well. We look at the treatment criteria that we have received and that we use from the NICD of individual. In the first phase, the bloods that we take when we admit individual to assess the severity of the disease and where individuals are. and the type of treatment that we need to give to our patients. Most of the patients that come through with saturations of already 60% are already in the cytokine storm. And we have realized that between these ages of 50 and 59, when they arrive with saturations of about 60 to 70%, we have a window of about 2 days. If they are not in ICU within 2 days, they seem to perish. And the challenge that we are facing currently is the number of beds that are available in ICU. We also, immediately when they arrive, we look at the D-dimer, and we already start them on the treatment on Clexane, because we know that if they develop thrombosis, or if they develop thrombosis because the D-dimer is high, the prognosis is actually quite poor. We also look at the interleukin 6. Interleukin 6 results in severe organ failure. And if they are in organ failure, we start them on the treatment asymptomatic and interferon, and we assess them continuously until we get an ICU bed. If we don't, we continue. We've had 2 successes, 2 gentlemen, moderately obese, BMI greater than 35, weight around 150, whom we had succeeded to treat, who complicated a lot with severe hypoglycemia, were on CPAP for 2 weeks, and then we'd scale them down to rebreathing mask and then nasal prongs. 1 is still in the hospital on nasal prongs, 1 we were able to send home. We have noticed that the moderately, morbidly obese patients are the ones who tend to suffer with severe respiratory distress initially, and especially when they arrive. And it looks like it actually takes a long time for us to wean the oxygen off. Between 2 weeks to 3 weeks, they will be oxygen dependent. These are just to show the increase in mortality. When you have cardiovascular disease, we also monitor the troponin T, and we also monitor CRP when you're in hospital, put you on the right medication and assess your severity and risk of death. Most of these people, initially on assessment, the occupational health practitioners have actually assessed them and made sure that they are actually not at work, especially those with cardiovascular disease, diabetes, and hypertension. Initially, we did the awareness training, and these are just the posters of the initial awareness training that we did at Impala. And the declaration, as you see there, of my health declaration screen is seen at all the shafts. And it says by clocking, it means that I do not have a fever, I'm not coughing, I don't have any shortness of breath. So basically, these posters that you see, we have them at all the shafts, we have them in the community in Rustenburg, we also have them in town, so, and also at the schools where we did education. This is our IMS services. When you enter the gate, you wash your hands, and the social distancing entrance into our isolation wards. And also, it was initially before we divided with perspex, where we could issue files for the patients. This is our IMS EMS team, who have actually been taught in downing of PPE. And we also have, we fumigate our ambulances after they have gone to fetch a patient from the shafts, fumigated, cleaned, and decontaminated, and left standing for 45 minutes. We have allocated 3 ambulances basically to respond to the shafts. We also have different, about 4 vehicles, 22 seaters that fetch employees from the different areas in the shafts. The lower pictures basically show you the rooms where the doctor assesses the individual. performing a nasopharyngeal test. And the other one is a group of people at Maharing. This is just outside room 5 and 6 where the doctor was performing that test. And then this is inside the room where the doctor was performing the test. This is physio, which looks much different from now. This was initially where we were identifying the space where we will assess and test our individuals. This is our isolation facilities in the hospital, our high care areas, and each isolation room has got a bathroom, a separate bathroom and a shower. This is Maharing, where we do quarantine and isolation. Bed capacity that we have is around 3,200 beds. But if you look at the population that we cater for 40,000 employees together with the dependents going up to 57,000, it's not enough. But however, we are identifying other facilities where we can assess our individuals. This is how initially it looked at Maharing when we were renovating the area. It's got 3 separate bedrooms, a bathroom, it's got a shower, and a kitchen area that is open. This is the team that went to assess Maharing and see as to how they can renovate the area. And they were actually with the DMR was present together with our senior officials. Thank you very much. Thank you.
Thank you very much. That was Dr. Irene Mampa. I was just slightly delayed with my microphone there. Dr. Mampa, thank you for your contribution in sharing with us quite in-depth information about the processes, decisions, resources, and put in place in order to deal with the situation within your particular workplace. Our next presenter is, I'm going to just quickly ask our presenters who are still with us, that's Dr. Rametsi, Dr. Mampa, and Kim. If you are co-host, you can see the Q&A box at the bottom. If there are any questions directly related to your presentations in the Q&A box at the bottom, please just assist us in answering those questions related to your specific presentations. Thank you for that. Our next presenter is Mr. Gerard Woods from the Master Builders Association, MBA North, and he will be looking at the experiences in the construction industry. So good morning again, Gerard. Are you online? Is your microphone unmuted?
Yes, good morning, ladies and gentlemen.
Brilliant. Could you just share your presentation? And in the meantime, while Gerard is preparing that, please a reminder, in the Q&A box, that's only for questions. Please don't put anything else in there. It is going to be dismissed as the third column in the Q&A box is called. It will be put there. If data matters, please email hwstraining@witshealth.co.za, hwstraining@witshealth.co.za. For also certificate of attendance, please also email hwstraining@witshealth.co.za. And for only CPD points, you can email us at info@nih.ac.za. That is info@nih.ac.za, and that's only for CPD related matters. For certificate of attendance matters, that you will have to contact the Wits Health Consortium. So Gerard, did you manage to open up your PowerPoint and to click the green share screen button at the bottom? Gerard, you're muted. Gerard, can you just unmute yourself and can you?
Okay, now we're going to share.
Okay, please. Yes, thank you.
Thank you.
the PowerPoint, you click the green share screen button at the bottom, and then you find the small little box that is your presentation. You click on that presentation.
We're very slow in the brand.
Thank you.
Okay, we're done.
Good, ladies and gentlemen. May I proceed?
Yes, I see that you have started to share your screen. However, we're not seeing anything on our side yet. We just see Gerard Roots has started screen sharing. Can you see your presentation on your side?
Yes.
Okay, so we don't seem to see your full screen sharing. Maybe it's just a bit slow. I hope that your internet connection and bandwidth is has enough speed.
Yes, we are. The screen is shared currently, and we are also online with your IT assistant.
Okay, so we don't have a visual yet. We can hear you. The audio is very good. We can see a screen. Can you move your cursor? I just want to see if your pointer moves.
Yes.
Okay, you might be frozen. Okay. What if we try and share on our side, Gerard?
I'm currently sharing my cover page, Management of Persons Under Investigation, and the experiences in the construction industry.
Okay, we're not seeing that yet. So I'm just going to quickly see if you did send your presentation to us, but it's, I think, in a PDF format. And we'll just have to show that PDF format. Is that okay with you?
Yes, yes, thank you so much.
So give me a moment. Apologies, everybody. We just need to sort out this very quick technical matter. Does it say management of persons under investigation, COVID-19 experience in the construction industry?
Yes.
Okay, we can share it here from our side because I think we found it. Just see in your side if you can see it in a moment. It should be coming up now. One moment. So can you see that, Gerard?
Yes, I can see that. It seems like the connectivity is a bit slow, but I can view the page.
Excellent.
Yes.
So all you just do is say next, and my colleague Glenn will move your slide for you. So please proceed. Just as a very quick brief introduction, Gerard Roots is the MBA, Master Business Association North Construction and Health and Safety Manager. I hope I've got that right. Gerard Roots is been there since 2015. Gerard joined the association as a construction health and safety officer in 2009. His career started in 1994 with a 14-year stint at the Department of Correctional Services. He acquired an interest for occupational health and safety in 2002 when he attended an occupational health and safety course offered by the South African Federation of Civil Engineering Contractors, SAFSEC. He obtained a BTEC degree in safety management in 2012 through UNISA and is registered as a construction health and safety manager with the South African Construction Practitioners, the SACCMP. So, Gerard, thank you for joining us. Please proceed.
Thank you so much. Next slide, please. Right, with regards to the background of MBA North, the Pretoria Master Builders Association was founded in 1903 And the Johannesburg Master Builders Association was founded in 1994 and was formally constituted in 1904. These organizations merged in January 1996 to form the Gauteng Master Builders Association. In 2012, the association underwent a name change and is now known as the Master Builders Association North. MBA North is an employers organization serving in the interest of its members in the building and allied trade industries, registered in the building industry with jurisdiction in Gauteng, Northwest, Mpumalanga, and Limpopo provinces. Next, please. With regards to identify COVID-19 suspects, sample testing were conducted on 4 medium-sized construction companies operating in the commercial and residential construction sector. All 4 projects is located in Johannesburg and Pretoria. Between 150 to 400 people are working on these projects, and majority of the employees are employed by subcontractors. With regards to access control onto construction sites, screening will be conducted on all employees, visitors, and contractors requiring entry to the workplace. Before entering the work premises, employees should be alerted that if they are coughing, having fever, or have flu-like symptoms, they should please not enter the workplace. It is recommended that the principal contractor signs a CEO declaration with each subcontractor, whereby the subcontractor confirms that their employees was informed about COVID-19 prior to entering the site. Next, please. With regards to identify COVID-19 suspects and in terms of temperature screening, screening will be controlled by security personnel who are properly trained in doing the screening procedure. This procedure will be overseen by the appointed compliance officer on site. All security personnel who will be involved in the screening of employees also require screening before the start of their shift. A temperature check will be conducted on all employees entering the workplace. A daily symptoms questionnaire will be completed by each person entering the site. If a screening question is answered yes, or temperature is abnormal, access to the workplace should be denied, and that person should be managed by referring him to the site isolation room. Next slide, please. Then with regards to managing of COVID-19 suspected cases, employees should be refused entry into the place of work. A referral slip will be given and the employee will be asked to consult with his own healthcare provider. The name, surname, contact details of the employee and the contact details of the next of kin should be obtained and recorded in a referral record prior to the employee leaving the premises. The responsible manager should immediately be informed, and a mask should be provided to any symptomatic person before they are referred to their own healthcare provider. It is no longer required for an infected employee to test negative for COVID-19 before allowing back to work if they are self-isolated for 14 days. However, an employee will not be allowed back onto site until a medical evaluation of fitness is issued by an OMP or doctor in case of moderate to severe disease. Next slide, please. Thank you. Employee confirmed to be COVID-19 positive. Following the identification of a sick employee while on site, all potentially contaminated surfaces where positive COVID-19 persons worked should be cleaned with 70% alcohol-based cleaning liquid, for example, the floors, walls, contact surfaces, and large equipment. Sanitize contaminated instruments as per usual protocols, only where the infected person has worked. Cleaners need to wear protective PPE and wash their hands after handling any potentially infected material. All cases are reported to the NICD, the Department of Employment and Labour, and Department of Health. Employee will be required to self-isolate for 14 days. It is essential that the responsible manager maintains regular contact with all employees in quarantine and isolation. While the employee is in isolation, the employer should contact the infected employee on a regular basis to ensure company support. It is also recommended that the employer provide an EAP program to its employees. Next slide, please. Some of the challenges faced by the construction industry is delayed entry onto site, extended queues due to social distancing contributed to additional health and safety risks on site, which include traffic management as well. The honesty of employees, visitors, and contractors when completing the daily symptoms questionnaire. Additional resources to manage the COVID-19, which include additional resources and the appointment of staff, appointment of compliance officers, depending on the size of the project and the number of employees on site. Additional PPE, which include appropriate masks, sanitizers, and gloves. Additional paperwork and filing has increased, contributing to additional admin on site. Additional monitoring of COVID-19 protocols on site, which include frequent site walks. Additional costing, and lastly, additional training and inductions is a bit time consuming due to the social distancing and also the constant awareness training. Next slide, please. Some of the best practices and recommendations that the construction industry can share with you is that they have indicated to all employees that a company has their best health interest at heart. Internal company policies, procedures, and declarations to adhere to COVID-19 will include sick leave and disciplinary procedures. It is important to update your company policies and procedures frequently. The updated policies should also be communicated to all employees. Regular online meetings to discuss the latest legislation, challenges, and recommendations. This is where the principal contractor will liaise with construction managers and health and safety officers via Zoom meetings on a weekly or daily basis. Adhere to basic COVID-19 preventative protocols, which include social distancing, wearing of cloth masks, regular washing of hands, and general hygiene principles. Continuous awareness training, whereby you can make use of online training, webinars, on-site toolbox talks, and also induction training. Thank you. Next slide, please. That's from my side. Thank you very much for the opportunity. And my contact details is on the very last slide. Thank you.
So thank you very much for that. That's Gerard Roots from the Master Builders Association North. And Gerard had dealt with the experiences in the construction industry. So we've dealt with quite a number of focus areas. That's from an occupational health point of view. Kim Davies, on behalf of the South African Society for Occupational Health Nursing, SASON, had dealt with experiences as an occupational health nurse in a workplace setting. And then we had Dr. Lesego Rametsi, who dealt with the experiences in the banking industry, followed by Dr. Irene Mampa, who dealt with the experiences in the mining industry, and then finally that was Gerard Roots from the Master Builders Association North, who dealt with the construction industry. And I think we will all concur that there are very common themes across the finance, mining, healthcare as well as construction industries with regard to some of the measures we got to put in place to ensure that our employees and our fellow colleagues are in fact safe at work, are healthy, remain healthy at work, as well as if they do return from either lockdown, isolation, quarantine, being affected or infected by COVID-19, that we would know what to do and we would have an idea of what the role players and stakeholders are in the multidisciplinary team that Kim spoke about at the beginning. So we do not have much time. We've got 4 minutes left before we close. And I just need to answer, I was about to post it in the chat box, a question that people asked about the certificates of attendance. As Dr. Spoor indicated in the chat box, please email all queries with regard to certificate of attendance for this particular webinar and other webinars sponsored by the Health and Welfare HWSETA via the Wits Health Consortium. Email it to hwstraining@witshealth.co.za. That's hwstraining@witshealth.co.za. For certificates related to CPD matters, that's the slide. Thank you, Glenn. That talks about the CPD certificates that we administer for those professionals who are registered and in good standing with those 5 bodies there. We are looking at the others, although we're not sure if all the other bodies are in fact directly related to occupational health or occupational health and safety, but the ones that we have there, we've already managed to secure the accreditation. You can email us at info.nih.ac.za if you've got any queries with regard to this. A link will be sent out to you via email with a password, and then you can do an online multiple choice question there in order to see if you can get the 70% to secure the CPD points for your organization. Just to note that the South African Institute for Occupational Hygiene, SIO, will independently determine the number of points applicable for those who are occupational hygienists. And again at the bottom, for certificates of attendance, please email the HWS training@witshealth.co.za email address. So on that note, I need to just thank our panelists. That is Ms. Kim Davies, that is from SASON, the South African Society for Occupational Hygiene. Kim, thank you very much for taking the time to join us here today and to share your experiences as an occupational health nursing practitioner, former president of SASON. And thank you to Dr. Lisego Rametsi. Your slides I found very, very useful, and I think people complimented your slides in the chat box as very simple and informative, including those decision trees that impressed me. That was the banking industry experience, and a very, very detailed mining industry experience by Dr. Irene Mampa. Dr. Mampa, thank you very much for your contributions. Your slides were jam-packed with information. People were complimenting the depth of the information. I just hope that we were able to share your slides with the participants by uploading it on our website. Please just liaise with Dr. Nkululeko Tunzi, who was coordinating with you in preparation for this particular program. And then finally, thank you to Mr. Gerard Roots for his contributions on the construction industry and sharing his depth of experience and knowledge with regard to what happens also around COVID-19. And then I have a long list of names here of colleagues who are on the panel, and unfortunately I'm not sure if I can see all their names, but to start with my colleagues in the room, the IT colleagues, that is Tabani and Glenn, I want to say thank you so much for your contributions to making sure that all the time we are solving significant little problems on the go and on the fly. It sometimes feels like you're somehow keeping this airplane in the air when sometimes the engines are failing. But knowing that for now, those engines have always been going quite strong. And then to Simpiwe from the Information Services section, and his head of section, Angel Munzanele, who is responsible for ensuring that you as participants receive in an email the links, and that initially at the beginning you receive the invites as well as other uploading of the links, videos and presentations to the website with the support of the colleagues in the communications department headed by Shanaz. And then to our list of panelists, I want to say thank you very much to Dr. Samantha Yalo, Dr. Pume Daba, Dr. Odette Volming, to Gabriel Mazan, Gabi, thank you very much. Kateko Makubele, apologies. Dr. Charlene Andreas, Dr. Tanusha Singh, Dr. Tunzi, Jeanette Mangani, the head of the occupational hygiene section. Thank you very much. I'm not sure if I've missed out anybody. My apologies if I did. Thank you very much for your contributions as panelists, answering all the questions in the background on the Q&A section. And at this point, thank you for joining us today on the topic of management of persons under investigation, the PUIs, a new abbreviation we learned throughout the nation this year, the persons under investigation for COVID-19. And we've had the shared experiences of people from 4 different sectors. So thank you to Dr. Nkululeko Tunzi and his colleagues there in the HIV and TB in the workplace section, headed by Dr. Muzi Zungu. Thank you. We'll see you in our next webinar. Goodbye.